smokers in here? No? Okay, I'm pretty sure we all know people who do smoke. Pneumothorax, spontaneous pneumothorax, a nice big medical term, means collapsed lung. Pretty sure we all heard this in our past. And it's exactly what it sounds like. The lung is supposed to be inflated here, it collapses down because air gets inside your chest wall. Now, smokers have 102 times more of a higher chance of getting a pneumothorax or collapsed lung, according to CDC and my favorite website, eMedicine. Especially smokers between the ages of 20 and 30, which is everyone in this classroom. Someone in this classroom will get a collapsed lung sometime or another in their lifetime. Once that happens, you have bought yourself a chest tube, which is a tube that goes inside you and reinflates the lung. Now, this is a risky procedure that carries a lot of complications, and I'm going to show you all today how to utilize your setup correctly, manage your chest tube, and follow up. First, this is a sterile procedure. Sterility is the standard, no exceptions. So you will be properly draped. On the slide I was showing you properly draped, face mask, and using the techniques that Al showed us earlier, washing your hands and actually scrubbing in. Not only will you be sterile, the patient will be too. You'll lay out, it was on the slide, you lay out the patient and have sterile drapes around the patient using betadine to sterilize the skin so you can actually touch it, feel the ribs, and actually manipulate where you want to work. Now, next and the most important part is the setup in this procedure. Anything in surgery, any surgical procedure, preparation is key. Ergonomics falls a lot into this. You want to mentally go through it in your head and figure out exactly what you need next. Have it all ready. Have your lidocaine drawn up. Have the safety part of the scalpel removed. You want to have everything neatly arranged so you're not reaching over here and grabbing over here, asking the nurse to get something for you once you start going. You have to mentally get everything ready, because that's what's going to trip you up and that's what's going to lead to complications and lead to things being delayed. Next, importantly, is positioning.
Sit.
Yeah, sit and lay down.
Tell my fiance I love it.
This is one of the positions we'll have the patient in with their arm rested on, we have a device we put here to rest their arm. This is the area you want to work right over here. It's mid-axillary, or in layman's terms, mid-armpit. Nipple line is your anatomical mark. For guys, for females, you can just count down the ribs. But that's where you want to work. Go in fetal position.
This way or that?
Yeah, facing the wall. This is another position. This is the position I prefer to work in. I can have everything right here, have the patient propped up, and again, we'll have something supporting their arm. So you can work right here and actually mark the area. Okay, you can sit up. Alright, now that you have the patient position, you mark your area, you have everything set up accordingly, now it's time to actually start working and actually start getting into the chest. As far as analgesics, lidocaine and morphine works very well. Patient is awake during this procedure. The patient's not passed out, they're not sedated, so they can hear everything and they can listen to everything that's going on in the room. And this is done in the ED or the patient's room. This is not done in the OR. So, so now we're ready to make an incision. Have a seat here, please. So once you have the patient once you get the analgesic in, you make a simple incision right over here. Small incision about this big, according to the nipple line. Now, this is a Kelly right here. This is your most important tool. This is a Kelly clamp. It's a clamp. It has a curvature. It has a blunt end. It looks kind of like a scissor. You can snap it closed. Once you make an incision, what you'll be doing is getting in that incision, and I apologize for being a little graphic and the actual barbaric nature of this, but you're actually creating a pocket, and this is the actual procedure you're doing. You're just moving up and creating a pocket and working on it there and making an actual space for you to get in there. Once you've done that, next important instrument, believe it or not, is your finger. You get your finger in there and you break up the loculations and separate the skin from the actual ribs. Now, once you've done that, you can clamp up and feel the ribs, and you know exactly where you want to be. Now, this is the time when you enter the chest wall. Take the Kelly, close it, get right above the rib, not below the rib, above the rib, And what I like to do is, I like to hold it, get nice leverage on it, follow the curvature of it, and pop right into the chest wall. The patient will scream as loud as they can. And again, I apologize for the barbaric nature of it. You pull open and you hear ripping and tearing of the fascia. At this point, you'll hear air coming out of it. You stick your finger right inside there. You do a sweep like this to make sure the lung is not on the actual chest wall. Get your chest tube ready, like this. Stick it right inside there. And basically the hardest part of the procedure is done. Now, I just said this is a very risky and complicated procedure that could carry a lot of complications. It may seem like I oversimplified the actual part of getting the chest tube inside the patient. And that's because I did. It takes about 5 to 10 minutes to actually get the chest tube in the patient from making an incision. It takes about 45 minutes to an hour and a half to set up and get everything ready, just to show you how important how important your setup is and how that can lead to getting the chest tube in the patient like that. Once you get the chest tube in, you have to secure it down with a regular suture and actually secure it in there. And once you've done that, you follow up with a standard chest x-ray to make sure it's in the lung and not inside the actual abdomen. So following correct setup, managing the chest tube, and following it up, you can safely place the chest tube inside the patient. And hopefully the patient recovers and the lung expands full.